All right, so we're gonna change gears now, and we're gonna talk about the disease. The disease, we see the patients, we see the procedures, we see everything macro. Now we're gonna go micro. Good. So first question: 64-year-old female, class 3, chronic stable angina, risk factors, and she went for an LAD PCI. Now, you did the OCT, you find this proximal to the non-obstructive, big lumen, but something weird here. Which is the correct, because all of the above are false except, which is the correct statement? A, the imaging is suspicious for a thin cap fibroatheroma. The lesion is lipid rich. There's mild calcification is observed. A and C are correct, or all of the above are false. B? Very good. That is a very good statement. See, contrary to ultrasound, when you have a shadow, because ultrasound doesn't penetrate, light has penetration and can see behind calcium, and you can delineate it. So we'll talk about it. Now, the lesion observed in this OCT image shows a thin cap fibroatheroma. Will reflect 180 to 200 degree shadow on IVUS. It's predominantly lipid rich. 1 year MACE and death can be up to 19 and 6% post-PCI. A and C are correct. B and D are correct. You don't talk. You guys talk over there. The right side of the panel. Front row here. Which is the right answer? E and C, A and C are correct. It looks like a thin cap fibroatheroma, huh? But if you have lipid, you see nothing behind. What calcium is for ultrasound, shadow, lipid is for OCT, shadow. We'll talk about it. So is B and D? B, 180 to 200. Yeah, more or less. And wow, these statistics are tough. Huh? Look at this. Who can believe that? All right, so calcium appears as a signal poor region. Signal poor, you see, is almost black. We could do like radiolucent or echolucent, but signal poor with a sharply delineated border. Sharply delineated border. Okay? And will reflect, 180. We start here, and this will be 180, almost 200 degrees shadow, because ultrasound doesn't penetrate calcium. Okay? So this is important because you guys are going to do more ultrasound or more OCT, and ideally do OCT more so you get familiar. Because if you jump to practice and you don't do it, then you won't do it. Forget about it. Who's going to do it? Okay? This is data from Dr. Sharma's talk. He uses it in his conferences. Cardiac death, 6.3%. MACE, 19.9%. For severe calcification. So those were good. Now, where did all this field of calcification started? It started in the 1950s, mid-20th century, when Dr. Blankenhorn, a pathologist, actually published in the Journal of Radiology and two different publications, he was looking for Munkeberg disease, which is calcification of the tunica media of the large elastic vessels, the lower extremity. But he was looking for that in the heart. So he did 76 autopsies, and he realized, he did an X-ray, still do it, the pathologists do an X-ray of the heart, before they go and open. They still do it. And he documented the calcification, but 99%, actually all of them were in the intima, not in the media. There was no Monkever disease in the coronary arteries, no Monkever. And when they said, oh, the calcium is in the media, forget about it. There's exceptions, like end-stage renal on dialysis may have 1 or 2 cases in the pathology described of tunica media calcification. The calcium is in the intima. That means it's pathognomonic of atherosclerosis. So if you have a lady with a calcium score of 70 at age whatever, 50, 60, she has disease. And the disease may not be obstructed, but doesn't mean it's not advanced, because that's the other thing. And we'll talk about it later. So Monkever, you guys know this, but it's important to remember. And there is this formation and resorption of calcium. And the osteoblasts, the non-collagenous proteins, are responsible in yellow for formation of calcium from using vitamin D and actually calcitonin. But there is resorption of calcium from the bones, specifically in renal failure. See, you measure parathormone in patients on dialysis. They can be up to 1,000. Actually, that's my first study that we, as a resident in medicine, we did a randomized trial. It was, with the attendings and all these, giving those days where some medication to antagonize parathormone in patients with dialysis. And we measure, and it was in the 700s, 800s, 1,000. So it's impressive how this parathormone is responsible. That's what it's called, tertiary parathormone, hyperparathyroidism. So you will see it in calcific patients. So your rotablator or your orbital is your friend when you do end-stage patients. And in the natural history, you can see that all these osteopontin, all these collagenous proteins has a mechanism of action very similar to what we know about athero, okay? So that's the pathophysiology. That's the pathophysiology of calcification. You can measure it. Actually, in diabetes, it's higher. You can measure it in patients with multivessel disease. And it's called dystrophic calcification. Calcification that is not on the bones is pathologic. And it's called dystrophic calcification. So because calcium is going to be one of your daily activities in life from now on, calcium is going to be not only a daily activity, but a common friend or foe, whatever you want to call it. It's a friend when it's straightforward and nice and you can rot. It's a foe when it's complicated and you have to talk to the surgeons. Now, is calcium directly proportional to the size of the plaque? This is the square root of the calcium area, and this is the square root of the plaque area. Or is calcium related to stenosis? The answer is here. The square root of the lumen area has nothing to do with the square root of the calcium area. Here, the R value is 0.52. So when you have an R value of 0.52, that means that 48% of this relationship is not related to the two. Very important to understand, because in linear regression analysis, you look at this p-value and you're so very impressed. But no, you have to look at the R value, okay? So there's a lot of reasons why these are related, but they might be a reason that is significant. So the reviewers of the paper accepted this because in human stuff, more than 0.5, 0.6 is a good R value. So you classify these: no calcium, mild, faint radiopacity, knowing during the cardiac, moderate, dense. But you can severe is if you have this tram rack. You know, the tram rack, you see both With just fluoroscopy, you see both ends of the vessel. That means 360. You don't need OCT. You don't need IVUS. You have to rota. I mean, unless it's very, very focal. But be careful with the mid and this distal LAD lesions like that. Because then you start inflating. You dissect, and then you don't want to do this. And, forget about it. Okay, now what is the incidence? When you do 100% of, you see that a third, I mean, there's a total of what, 700. So there is about 30-40% of them that are going to be significant calcification. And this is the trem rack. You see it here. You don't need to inject here. If you want to intervene this, you cannot do it with balloon angioplasty. And you saw the discussion yesterday about this. Next question. So which is the false statement here? Dystrophic calcification is mediated by non-collagenous proteins expressed in macrophages. Severe calcification is associated with increased mortality after PCI. Coronary calcification is associated with the severity of coronary stenosis. Coronary calcification is mostly present in ruptured plaques. Oh, it's a tough question. Over there. Anybody want to jump? Which is the wrong answer? See, coronary calcification. I just told you guys. Didn't I tell you that? Didn't I tell you here? I told you. Severe calcification has nothing to do with luminaria. So why is this thinking twice? Just answer like this secure man. The question is, why is that? Why is that? Why severe calcification is not associated with stenosis? We know that. You remember the EBCT, calcium score 2000, stress test negative, angiogram, mild disease. It's a complicated question. Why not? I mean, calcification is almost end-stage coronary disease by histology. I'll show you that in a little bit, by histology. It's very advanced disease by histology. It's actually the death of the metabolic activity of the atherosclerotic plaque is calcification. I call it the coffin, the burial of the plaque. There's no lipid, there's no inflammation, there's no neovascularization, there's no activity there. It's a bulky, dead plaque, but it's bulky. And why it's not directly related to stenosis, which we know it is because of, maybe the answer is here. What all of the following statements regarding are true except, which is the wrong answer. The type 1 lesion. Type 1 lesion is in the American Heart classification. It's protoc-like and rich and prone to develop athero. The type 2 lesion, the fatty streak, is characterized by foam cells and infiltration and may regress. Type 3 lesion, the pre-atheroma, is characterized by pools of intracellular lipid and collagen. Early lesions are flat, always asymptomatic, and do not obstruct the lumen. Which is the wrong statement? Okay, I switch gears a little bit, but the important thing here is how atherosclerosis evolves. This is the most fascinating part of the disease, is when things go wrong. We can have a type 1 lesion, which is atherosclerosis, is a non-specific intimal thickening. That's type 1. Non-specific intimal thickening. Type 2, the fatty streak. Fat is intracellular in the fatty streak. The macrophage, the giant cell, is full of lipid droplets. But that cell, automatically overloaded with lipid, cannot give the free cholesterol to the pre-beta HDL, which is the reverse cholesterol transport. That's why that cell is in there, trying to clean the minimally oxidized LDL, convert it into free cholesterol and give it to the cassette, ABC1. I'll show you that. The cell dies by hypoxia or by apoptosis. And then it becomes the type 3 lesion, that the lipid pools are extracellular, not intracellular. That's a difficult question. I know. That's why I didn't ask. Let's go into that, okay? Classification. Early lesions, non-specific intimal thickening, also called adaptive thickening, foam cells, type 2 lesion, pre-atheroma, small lipid pools, advanced lesions. Atheroma, fibroatheroma. Type A is the fibroatheroma, thin cap fibroatheroma. Type B is the calcific, and type 3 is the fibrotic. So in the histological classification of athero, just before you go to the morgue, you get calcium, okay? So it's very advanced in the disease, although the lumen is not affected, because we're not looking at the lumen. We look at the lumen by serendipity or by mistake because we want to treat the patient because he's symptomatic. But the disease is not in the lumen. The disease is in the vessel wall. That's why you have to be obsessive about this. If you don't know, you miss the game. You're out for lunch. If you don't miss where the disease is and you don't understand the disease, you have no pleasure practicing interventional cardiology. You become an operator. And it's egotistic, to be an operator. I mean, why not? And on top of that, we make a living. It's good. But you miss the whole thing. It's like going to the Louvre Museum and study zero, or going to the Central Park and just go throughout and not enjoy it. So calcification, microcalcification, coarse calcification, coarse dense calcification. This is not picked by the CT angio, unfortunately, but this one, yes. With the CT or the EBCT, you can get up to, when it's about 1 millimeter square, you can see it. So we're going to move fast forward to the complex lesions, because that is important. And the complex lesions are plaque rupture, where the lipid core is in contact with the flowing blood. There is extrusion of lipid, which is thrombogenic and generates this. So the definition of plaque rupture is when the lipid core is in contact with the lumen, with the flowing blood. The definition of plaque erosion is when there is no contact between the lipid core and the flowing blood, and you have a clot. Simple. So now you don't forget what is plaque rupture and what is plaque erosion. In plaque erosion, no contact between the lipid core and the thrombus. In plaque rupture, contact. Okay? And what is this? Intra-plaque hemorrhage. Intra-plaque hemorrhage. Those are the three type 6 from the Starry classification, American Heart Association 1995 classification with Dr. Fuster and others, Bob Dinsmore, and complex plaques. Erosion, rupture, and intra-plaque hemorrhage, the three, okay? What happened here? Multiple ruptures, healing, type 3 collagen, repair collagen. Very nicely here. Another plaque, advanced disease, obstructive disease, probably harmless, but very, very symptomatic. Question here. All of the following statements regarding early angiogenesis in atherosclerosis are true, except, which is the wrong answer here. The tunica media drives oxygen from the lumen by diffusion. Hypoxia evolves when the distance between the lumen and the tunica media is greater than 0.5 millimeters. The molecular process of angiogenesis is driven by hypoxic inducible factor 1 alpha. That sounds to be true. Huh? Let's put that aside. Neovessels are characterized by structural tunica media and pericytes. Neovessels evolved from adventitia vasa vasorum, but progenitor cells may also contribute. Okay, I'm not going to ask. I'm going to give you the answer. All of these are true, all of them. So remember, the tunica media, the tunica media has smooth muscle cells. It's composed by the elastic lamella, described by Dr. Glagov, Simon Glagov, Glagovian, sounds, rings a bell. In the 1960s, 1964, 1966, he published a beautiful paper, and he studied the tunica media on mammals, from the rodent to the whale, circulation research paper. And he found that every mammal has this elastic lamella composed by 2 fibers of elastin, and in the center, the smooth muscle cell. 28 plus minus 4 elastic lamellas in the tunica media. Because the tunica media is the structure of the vessel. The intima is a virtual space between the endothelium and the internal elastic lamina. Virtual space. Some little collagen, because of the Laplace law, some proteoglycans there. But when we are born, the tunica media is a virtual space. The tunica intima is a virtual space. The tunica media is the smooth muscle cell that contracts and relaxes and maintains volemia. See? When you need more blood, you dilate. When you are hypovolemic, you contract. So this tunica media needs oxygen. It comes from diffusion because there is no intima. But the other tunica media, the other, which is in the back, close to the adventitia, they get the vasa vasorum from behind. Okay? So these are 500 microns. This is a fatty streak. And what happened here, this is a fatty streak. This is in electron microscopy. I told you about the fatty streak. I told you about the giant cell. This is death macrophages. Like Michael Davis, the father of pathology, of modern cardiovascular pathology with Renu Virmani and others, they describe the lipid core and then the necrotic core, which is the more advanced phase of the lipid core, as the cemetery for macrophages. That's where the macrophages are dead. You will still have the membrane of the cell, so you can identify macrophages by immunohistochemistry, but they're not active. And now the lipid is extracellular. And it happens mostly in this area, in the intimomedial junction. This is the median, intimomedial junction. Why? Because it's more than 500 microns. From here to here, more than 500. Hypoxia, death. Actually, the oxygen has been measured there, and it's about 20. So which aerobic cell can survive a PaO2 of 20? Forget about it. I told you about this. The macrophage, this is an easier slide. I don't want you guys to get a little tired now. This is an easier slide because it's the macrophage. And the macrophage has the free cholesterol. The free cholesterol, FC, the function of this cell is to use the cassette ABCA1, ABCG, and SRBI to give the free cholesterol to the pre-beta HDL. Okay? Reverse cholesterol transport. That's what we do when we give rosuvastatin, when we give PCSK9, when we ask people to stop eating the burgers. That's what we are stimulating. So we actually did. We are now in the yellow 3 study at Sinai, but we have done 2 yellow studies showing regression of the lipid component of the advanced disease by near infrared spectroscopy. We measure the lipid core burden index, and we reduce it by 50% with 7 weeks of aggressive lipid lowering therapy below 60. So you can regress the plaque. You have to understand how you regress it through this mechanism. So this is the neovascularization that I told you about, the vasa vasorum. And this is the hypoxia. If you measure hypoxia, this hypoxia marker NITP, it is always in the intimomedial junction. Let's move on. This is vasa vasorum from the adventitia. This is vasa vasorum from the lumen, but there's much more from the adventitia. So very little from the lumen. And these are data with neovessels that they have no tunica media, they have no pericytes, it's only a microendothelial layer that can be nicely stained using a blue chromogen attached to CD31, which is an immunohistochemistry to identify the endothelium. CD31, CD34, or von Willebrand, any of the three you can use. And here you see in the tunica media, alpha acting for the smooth muscle cell, the neovessel. See? The neovessel is going from the adventitia through the tunica media into the intima, into the fibrous cap. This is the shoulder. And if you measure that, you can see non-specific intimal thickening, fatty streak, pre-atheroma, atheroma, thin cap fibroatheroma, calcific plaque, fibrotic plaque, rupture plaque, or thrombotic plaque. Those are the classification, and you see the amount of neovessels. See the amount of neovessels, much more in the rupture plaque. The rupture plaque and the size of the plaque is huge compared to the other plaque. Look what here, calcific plaque, fibrotic plaque, nothing, no neovessels, very little. Almost like the early plaques, the neovascularization. So you see it here, we quantify that, and I'll show you these fibrotic plaques, see? Fibrocalcific, contrary to the lipid-rich and the rupture plaques, who has a lot of neovessels, the fibrotic plaque, no metabolic activity. Give us trouble because the balloon doesn't expand and all that, but has no metabolic activity. Let's move on. So another question. All of the following statements regarding advance are true except the type 4 lesion. Type 4 is the atheroma, okay? Have lipid core, but still do not have a well-formed fibrous cap. The thin cap fibroatheromas are characterized by a cap thickness less than 65 macrophages and a large lipid core. Extravasation of red blood cells within plaques increases lipid core expansion. Plaque rupture is more frequently symptomatic, leading to acute coronary events. Which is the wrong statement here? All of them look like true, huh? D. Plaque rupture is more frequently symptomatic, leading to acute coronary. Everybody agree with this? Or everybody disagree? No comments. Okay. An acute coronary syndrome is the exception and not the rule of plaque rupture. Out of 100 plaques that rupture, 1 give you syndrome. Why? Because that's the way the plaque progresses. And it's totally asymptomatic. It's a little mural thrombus, it gets healed, and then the next plaque forms on top of that. So that is the wrong statement. All of these are true statements. See? Complicated question, huh? Let's see it. Yeah. Okay, diabetes. You have more intra-plaque hemorrhage, more neovascularization, more inflammation. Remember that. And when the red blood cell goes out into the plaque because there is extravasation from this microcirculation, the pH is 2, it's acidic component. The endothelial cannot handle that, it ruptures, and the red blood cell goes extravasation. It's called also the corpuscular is out, and then it's a problem. We're gonna just spend the last 2 minutes about intra-plaque hemorrhage, okay? What is this? All is following are true except plaque neovascularization can be identified through the media into the intima. You know that, huh? From the media to the intima. Intra-plaque hemorrhage is associated with increased neovascularization. Not difficult, huh? Diabetic plaques exhibit increased inflammation and neovascularization. Red cell membranes are cholesterol-free and decrease plaque expansion. That's the wrong statement. This is very important. This is the take-home message. You know, if you do non-obstructive carotid disease, and a recent paper just came out 2 weeks ago in JACC, exactly the same, going up to about 10 years. The plaques, non-obstructive plaques that have intra-plaque hemorrhage, they have 5 times more strokes compared to the same plaques by stenosis, but no intra-plaque hemorrhage. 5 times more strokes. And what is the magnitude? This is the only slide that I'm gonna show you and that you're going to hear probably about the importance of intraplaque hemorrhage in the evolution of atherosclerosis. Because this is a field that is not being studied because there's no way, only in the big vessels, you can see it by MRI. But in the coronaries or even in the periphery, it's very difficult to document intraplaque hemorrhage. But if you go ahead and do histology, and you mark the necrotic core with glycophorin A, which identifies the membrane of the red blood cell, you will see that the amount of red blood cells by computerized planimetry is equal or very, very common, very, very similar to the actual amount of the necrotic core. So they're permanently bleeding, these microvessels, which are there to supply oxygen to the red blood cell, to the macrophages and the smooth muscle cells that are requesting oxygen because they are hypoxic, they are bleeding, and they are expanding the necrotic core. Let's see if we have some questions just to finish. All of the following statements regarding advanced athero are true. Coronary calcification predictor of future coronary events. Yes. What is the incidence of acute events in a patient with a calcium score greater than 1,000? 25% per year. So it's important. Coronary calcification always reflect advanced disease by history. Yes, I told you that. Plaque erosion is more frequent in the smokers. That's correct. Chronic stable angina lesions are frequently healed ruptured plaque. Yes. And plaque rupture more frequently occurs at the center of the fibrous cap. Wrong. At the shoulders. Okay. We also see angiogenesis is responsible for intraplaque hemorrhage, but neovessel density is increased in large calcific plaques. Wrong. Neovessel density is decreased in large calcific plaques. Okay, I think it says, I don't know if I have another minute, maybe? Just 1 minute. Let's finish this slide. Atherosclerosis starts in utero. Before you're born, you already have it. Okay? It could be asymptomatic for many years, as you all know, and then it becomes symptomatic even by ACS or by symptoms, even chronic stable angina or silent total occlusions. The majority of plaques that induce MI, when they are seen 6 months to 2 years before the MI, are non-obstructive plaques. But if you look at the follow-up of non-obstructive plaques, the rate of occlusion at 5 years is very low, less than 2-3%. Actually, plaques up to 80% only go 10% to acute occlusion, and only the very severe plaques go to acute occlusion 5 years after. So there is a dilemma here. We see that the plaques that give you MIs are predominantly non-obstructive. But when you analyze the non-obstructive plaques individually, you see they are almost harmless. Huh? Complex, huh? So let's finish with this question. All of the following statements are true except non-obstructive lesions are the most frequent cause of acute MI. Obstructive lesions can evolve into complete occlusion silently. The individual risk for plaque progression to complete occlusion is higher in obstructive lesions. Atherosclerosis starts in childhood and can be seen in the second decade. Nope, it starts in utero. So remember, the individual risk for plaque progression to complete occlusion is higher. Of course, that's why we treat the patients. We treat severe disease. We don't intervene in early disease. Oh, if you take the massive multiplication of small plaques that are lipid rich times 40 to one severe lesion, yeah, the small plaques will give you trouble if you don't give treatment to the patient. I'm going to open this for questions. Anybody has questions?
Yeah. But if the calcified plaques, they are metabolic inactive, then why do these patients have more events?
Very good question. So the calcification is a marker for advanced disease in other areas. And there is a component of advanced calcific plaques that can give you obstruction. And the obstruction is really an obstruction and even thrombosis that is related to rheological components. See? Endothelial damage and stasis, like the triad of virtue. But if you look at the cells and you mark for macrophages and you mark for lipid and you mark for neovessels, they are very much not active. So very good question. Anybody else? Okay, guys, good luck.